Ji, Assalamu alaikum. It's Dr. Sajjad Naseer. Can everybody hear me clearly?
Yes, Sajjad, I can hear you at least. So,
Okay, great, great. Thank you very much. Thank you very much, everyone, for joining us today in today's Grand Round. The topic which I choose today for the Grand Round is pertinent to while living in Islamabad with so many patients of asthma we see throughout the year. And I picked up sort of slightly, I would say, higher end of the asthma, which we normally see, just to give a flavor of the condition which we commonly see in our day-to-day practice in pulmonary medicine. So I will start if all of us we are ready. So
yes, Sajjad, go ahead. Yeah.
sorry.
I said, yeah, please go ahead. Yeah.
Yeah, sure. So I think the objectives of today's grand round would be that first of all, we need to sort of define what exactly difficult asthma is. What are the factors which could be preventing a response to asthma medication before we can label someone as a difficult or a brittle asthmatic? Then what are the risk factors for difficult asthma? The different phenotypes of difficult asthma we come across and the treatment options which are available. So asthma ideally should not be difficult because as we all know that because of the modern pharmacotherapies we have, the new inhalers, the new immune therapies, the new insight into the novel anti-immune therapies, antibiotics, it should not ideally be difficult. Similarly, in terms of getting more and more understanding of the controls and triggers of asthma, and above all, with the airway inflammation, microbiological and molecular understanding, and at the end, because asthma, we all know, is a variable airflow obstruction. It's not a fixed airflow obstruction, just like COPD. So ideally, it should not be difficult because we know about the treatment options we have, we know about the causative agents we have, we know about the underlying disease process, we know that it's reversible, so it should not be difficult. Now, having said that, as we all know about this, right? We've been studying through our medical school. We know that asthma is normally triggered by allergens, and as they enter into a body, they start a cascade of immune response by first of all stimulating the mast cells, which then release different interleukin mediators, which then stimulate the basophils, the B cells, the T helper cells, and then that as a result leads to stimulation of T helper cells too, with the release of further histamine neurophines, IL-8, TNF, IL-3, IL-5, histamine, PGD2, LTC4, and that as a result leads to eosinophilic stimulation, neutrophilic stimulation, smooth muscle hypertrophy and contraction, and nerve cell stimulation. And that as a result leads to bronchoconstriction and a cascade of inflammatory mediators. Now, depending upon the phase of inflammation, either it could be an initial early response or it could be late phase response. So I think looking on the slides looks very easy. We know that what are the triggers, where the inflammatory markers are, and what could be the target inflammatory and cells and mediators which can be targeted to have a better control of asthma. However, in spite of the better understanding we have, sometimes it is not that easy to manage asthma, and we come across patients who are sort of quite difficult to manage considering their underlying bronchial hyperresponsiveness. Now, I would just briefly go through about the sort of the normal asthma we see, that what should be the strategy for the diagnosis. We all know that it starts with the history of the asthma onset, where we tend to see what is the age of onset, what is the trigger factors, how is the response to the treatment, any history of smoking in the background, which I would explain in the next few slides and why it's very important. Then we would like to know about the severity of disease, which would include exacerbations, hospitalizations, and previous ICU admissions. And I think most important thing in the history is the exogenous and endogenous aggravating factors, which could be in form of allergens, occupational agents, more importantly, drugs and foods which can trigger asthma. And then there are certain endogenous aggravating factors like rhinosinusitis, gastroesophageal reflux disease, obstructive sleep apnea, effect of menstrual cycle, and psychiatric illnesses. And I think most importantly, in terms of the strategy for managing and diagnosis, is to have a good background of the psychosocial circumstances and the adherence to the treatment. In terms of physical examination, we have to sort of look for the BMI, any other comorbids, and any other conditions which can mimic like asthma, like cardiac failure, and any other adverse effects of any previous treatments given. For diagnosing in terms of laboratory tests, we have a few things like peripheral blood, where we look for the eosinophil count, IgE levels. We look for thyrotoxicosis by doing the thyroid function test. In terms of the pulmonary function test, we can use the spirometry flow volume loop. We can go for peak flow, diary, methacholine, or mannitol challenge test, and arterial blood gases can be useful for diagnosing and managing asthma. Radiologically, chest X-ray, CT scan, CT sinuses are very useful. And then there are additional tests for looking for comorbidities and alternative diagnosis, which is a very long list. But the most important things we use are the autoimmune profile, aspergillus antibodies, and D-dimer test, and the endoscopy for looking for the reflux disease. So to summarize, as per the asthma management prevention guidelines, the diagnosis of asthma is based on the symptoms and medical history. They have to be sort of diurnal variation with symptoms getting worse at night and awakening. Because of exogenous factor, it could be a seasonal pattern for the symptoms, and then there could be a background history of eczema, hay fever, or a family history, and a hint of a trigger like an animal fur or chemical or any other thing which can trigger the asthma symptoms. And ideally, as we know that it's a reversible airflow limitation. So the symptoms normally respond to anti-asthma treatment and particularly to steroids. And one of the common symptoms which patients can mention is that they tend to get flu-like symptoms and cold, which never go easily, and it goes to the chest and can last for days and weeks or months if they're not treated at time. In terms of the diagnostic test for asthma, we all know that there's no single test which can secure a diagnosis of asthma. Spirometry is very useful. We use the mannitol and methacholine challenge testing. And if there's an increase in the FEV1 of more than 12% or 200 ml after the inhaled bronchodilator or methacholine or mannitol challenge test, we diagnose asthma on the challenge test as per this criteria. However, we all know that in spite of all the different testing, many asthma patients are negative with all the tests we have done, and repeat testing is usually advisable. This is just a brief overview of the treatment pentagram which we normally use. We normally start with the short-acting beta agonist as on required basis, then moving to the low-dose steroids of 200 to 800 micrograms per day. And then if the symptoms are not improving, we move to step 3, where along with the short-acting with the steroids, we use the LABAs or the long-acting beta agonist. And if the symptoms are inadequately controlled, we increase the dose of steroids to 800 microgram along with the LABA. And if there's no response to the LABA, we can either increase the steroids, or we can use other things like the montelukast or theophylline. In spite of all these measures, if symptoms are not getting controlled, we can go to the high dose of steroids by going to 2000 micrograms per day, or we can add other medications like leukotriene receptor antagonist, theophylline, or beta-2 agonist tablets. And the step 5 is if the symptoms are not well controlled, we can either go for the oral steroids in terms of low dose steroids, gaining us the control, And then there are certain other medications which I'm going to discuss in the next few slides if the symptoms are not well controlled in spite of the high dose inhaled steroids and the LABA medications. So after going through briefly about the normal asthma, which you mentioned, we'll go about the difficult asthma. Uh, there are different names which are given to difficult asthma, like severe refractory asthma, difficult to control asthma, brittle asthma, severe asthma, therapy-resistant asthma, steroid-dependent asthma. And it all depends upon the different phenotypes which we come across in difficult asthma. So how we define a difficult asthma? The definition is that patients, if they are still having symptoms in spite of the maximal dose of 200 micrograms of steroids, along with the LABAs, beta-2 agonists, theophylline for more than 6 months, they are having persistent daily symptoms, they are having frequent exacerbations, and they are requiring the oral steroid for the control and maintenance with frequent courses of oral steroids. According to the ERS, European Respiratory Society Task Force, failure to achieve asthma control when maximally recommended doses of inhaled therapy are prescribed for at least 6 to 12 months. Now we'll come to the second objective of today's talk after defining difficult asthma, that what could be the factors which prevent a normal response to asthma medication. And I think I picked that one up before I go to the depths of difficult asthma, because I think this is the first thing which most of us as clinicians, we don't concentrate on. And that as a result to lead to poor control of asthma, and as a result, lack of response to the conventional therapies which we normally give. Now, the factors which could be preventing a normal response to asthma medication, either it is an incorrect diagnosis to begin with, either there is continuing exposure to the sanitizing agents or the trigger agents, either there is unrecognized aggravating comorbids which are responsible for the lack of treatment to the asthma medications, and last but not the least, and I think the most important of the factors in our part of the world is the non-compliance with the therapy. So in terms of incorrect diagnosis, as a clinician, we have to look for the other clinical conditions which are mimicking asthma in terms of the symptoms and signs. Most importantly, like COPD, congestive heart failure, and ABPA, Schruck-Strauss, and then there are rare conditions like central airway obstruction because of foreign bodies, tumor, sarcoidosis, tracheobronchomalacia, recurrent PEs, obstructive bronchiolitis, recurrent aspirations, and vocal cord dysfunction. So just to give an example, that was one of the patient who had symptoms of asthma, but on further investigations was not responding to the inhaled steroid therapy, was found to have a depressed inspiratory loop on the flow volume loop on the pulmonary function testing. And on a CT scan, it found to have a lesion or a tumor, which was found to be a pseudotumor causing obstruction to the airflow and causing symptoms similar to the asthma. And after removal of that tumor, the flow volume loop gets normal and the patient is cured. So in spite of being on the inhaled steroids for ages, which was not the correct diagnosis, the problem was completely different, and that needed to be addressed. Similarly, I picked vocal cord dysfunction because I think that's one of the other things which we commonly come across in our clinical practice, and our ENT colleagues and also are getting involved in that as well as a result, which is a very sort of historical condition and has been reported back till, in 1842, 1869, 1902, 1983, with the symptoms which are sort of mimicking the asthma. Vocal cord dysfunction can misquater as asthma. And in one of the studies, we can clearly see that vocal cord dysfunction was the reason for the symptoms in nearly 44 of the patients. And then there's a good number of patients who had both vocal cord dysfunction and asthma together. So they can both coexist as well, besides being solely responsible for the symptoms. And in terms of vocal cord dysfunction, the key symptoms for the PGs and the learners is that it's predominantly the voice symptoms. There is throat tightness, there's pain in the throat, and it's not responding to beta 2 agonists. It may respond to steroids, and the mechanism is the irritable larynx. And the key to the diagnosis clinically is that the symptoms are predominantly in the voice box rather than in the bronchial breathing tubes. And the different tests we use to diagnose asthma is the spirometry, which could be normal, which could be restrictive. The flow volume loop, I'll show in a second, shows a variable extrathoracic airflow obstruction. But the key to the diagnosis is the laryngoscopy with the paradoxical vocal cord movement. And we can do the provocation test to stimulate the symptoms, because we know that it's the laryngeal irritation which is responsible for the symptoms. And we can do the provocation either with 4.5% saline, and then we can do the inspiratory flu lobe or do the laryngoscopy to visualize the paradoxical vocal cord movement. As we all know that vocal cord open up during inspiration. However, in vocal cord dysfunction, they are sort of coming together rather than opening up during the inspiratory phase and causing the symptoms mimicking asthma. The flow volume loop is showing a very sort of variable airflow obstruction on flow volume loops in pulmonary function testing. Then there are rare conditions. I've seen probably 2 or 3 cases of laryngomalacia and tracheomalacia, which can mimic symptoms, and they can be diagnosed based on the CT scan. But most importantly, you need to have a laryngoscopy or a bronchoscopy to diagnose the laryngomalacia or tracheomalacia, which can mimic the asthma symptoms. So I think the first thing we have to make sure that the diagnosis is correct before we label someone as having a difficult asthma. And then other rare conditions like allergic bronchopulmonary aspergillosis and bronchiectasis can also mimic asthma with similar symptoms, and the diagnosis is based on a CT scan findings. Similarly, the gastroesophageal reflux disease can be another sort of condition which can mimic like asthma. And the treatment which we normally use for asthma has very little effect on the asthma type symptoms. However, it can be hard to identify in the beginning to make a diagnosis. So that's something which has to be kept in mind, and we have to involve our gastro colleagues in time to investigate that further for us. So after the incorrect diagnosis, the second thing which we have to look for is the continuing exposure to sanitizing agents, which can continuously expose and trigger the asthma symptoms and prevent a lack of response to the treatment. The allergens or triggers, they can be at home in form of the dust mite. They can be at work at occupational exposure. It can be food. It can be drugs. However, the most important thing I would like to highlight is the smoking, which can prevent the response to the conventional therapy and which can lead to poor control of asthma. Uh, in one of the studies, they have found different triggers, starting from house dust mite and going to egg white, contributing to persistent continuous exposure to the triggers and causing asthma type symptoms in spite of being on maximal therapy, and hence labeling the patients as having difficult to manage asthma. In terms of drugs, we all know beta blockers, aspirin-induced asthma or ANA, non-steroidal-induced anti-inflammatory drugs by working on the cytokines can trigger asthma-type symptoms, and AC inhibitors can cause dry cough, as we all know, and which can mimic as cough variant asthma and poor and lack of response to the therapy. In my clinical practice, I found that AC inhibitors are the sort of main culprit most of the times, where patients are having dry cough for ages. They have been tried with different inhaled bronchodilator and steroid therapy, and they are not responding. And the clue and trick lies as soon as you stop the ramipril or any other AC inhibitors, the symptoms go away within 1 to 2 weeks. So in terms of my own clinical practice, I've found that ACE inhibitors are the most common sort of culprit in causing dry cough and cough variant type asthma symptoms in spite of maximum therapy. Now, I think I would like to highlight about the smoking, and I think a lot of has been said and published as far as the smoking is concerned in terms of the damages. But the key thing which I would like to respond is that besides causing airways damage and lung cancer and so forth, smoking can also reduce the response to the steroid therapy in asthma and can also lead to lack of response and persistent symptoms of asthma if the patients continue to smoke. So in one of these studies where they're comparing the non-smokers with the smokers, we can clearly see that the change in the mean peak flow in the placebo and steroid group, in fluticasone group, we can see a significant improvement in the peak flow after starting the therapy. However, in the smokers group, we can see that the lack of response both in the placebo group and as well as in the fluticasone group. In that study, we can see that it's going towards the negative side. So in fact, it contradicts the response to the inhaled corticosteroid therapy in patients with asthma who continue to smoke. So I think the most important message as far as the lifestyle modification is concerned in asthmatic patients is to stop smoking, because it can also reduce and negate the effect of the inhaled steroid therapy in asthmatic patients. Uh, in one of the other study where the study the effect of oral steroids between the non-smokers, ex-smokers, and current smokers, we can clearly see that in non-smokers, there's a very significant change in forced expiratory volume one after using prednisolone 40 milligram for 2 weeks. And gradually, even if the people have been ex-smokers, there is a significant difference between the two groups in terms of the change in the forced expiratory volume one, even being on oral steroids. And then with the current smokers, there is a very significant drop as compared to the non-smokers. And similarly with the asthma control, which is much better in the non-smokers as compared to ex-smokers, and then as compared to current smokers. So to emphasize, I think if I would like you guys to take the take-home message, if if you're not interested in the pharmacotherapy, that stopping the smoking not only have a positive impact on the bronchial airways, but at the same time, the response to the inhaled steroids, as we have seen in the previous slide, and in the current slide to the oral steroids, can be a significant difference between the current ex-smokers and the people who are currently smoking. Now, coming to the third part of our talk is to recognize the aggravating comorbids, which can also lead to difficult to control asthma. And there's a long list of conditions, but I would briefly sort of go through the chronic sinusitis, which can mimic the symptoms of asthma with persistent cough and flu-like symptoms, recurrent respiratory tract infections and bronchiectasis, gastroesophageal reflux disease. Obstructive sleep apnea can disturb the sleep and can mimic with the symptoms of asthma with nocturnal awakening, shortness of breath, difficult to breathe, psychological dysfunction, increased BMI, and some systemic conditions like thyrotoxicosis, which can present and mimic with the symptoms of asthma. And they can also aggravate the asthma symptoms if it coexists with the asthmatic patients. Now, in one of these studies, which was published a long time ago, they found that the different factors which predispose an individual to be coming into that category of difficult asthma is a female preponderance if there has been exposure to aspirin drug, increased BMI, and then a proportion of them had fixed airflow obstruction with increased residual volumes, which suggest the presence of structural changes. So this is something which is sort of relatively new, being discussed and talked about in most of the conferences, is about the concept of fixed airflow obstruction, which asthmatic patients, if they're not treated properly over years of their lifespan, with initial transition from the reversible airflow limitation, they go to fixed airflow limitation. And then because of that fixed airflow obstruction, the response to the conventional therapy is not satisfactory and leads to poor control of asthma symptoms. In another study, they found that sleep apnea, psychological issues, sinus disease, gastric reflux, and recurrent infections, they sort of coexist in asthmatic patients, and they can lead to a poor response to the therapy. Uh, Lastly, I would come to the non-compliance with the therapy, which is, as I've said earlier, is one of the very important reasons we come across in our clinical practice in Pakistan, because people have got doubts about the conventional therapies and the modern therapies we use in asthma. They've got doubts about the inhalers, that, concepts like we'll be going to hooked on asthma for the rest of our lives, whether it's the end stage therapy, uh, whether it is something which will cause permanent damage. So this is something, as a clinician, we have to spend some time to educate our patients that is just a type of a medication which you are giving through a route which is more appropriate, safe, and more effective. And it's nothing else. It's just that the routine medication, rather giving you orally, IV, or through nebulized route, it's best to give you through the inhaled route, which is more safer. The non-compliance could be due to many different reasons. It could be psychological issues. It could be because the patients are living with a chronic complex condition. It could be a lack of insight into illnesses. And it could be inhalation technique. Missed appointments are rare in Pakistan. I would say there are more late appointments, people coming late on their clinical appointments, or they're being missing their appointments. Now, I think as far as patients are concerned, and if they want to improve their compliance, we use ACAT score in UK, where we sort of, with the help of our asthma specialist nurses, we take them through the asthma management skills program, where they have a better understanding of their disease, they are taught about, and then as we know, that there are tons and tons and tons of new inhalers which have come into clinical practice, and they're all different in their usage. And the technique of inhaled device to be used properly is a very important thing. Then self-monitoring with the ACAT score, an action plan, and adherence, making sure that the patients adhere to the action plan, is very important in managing asthma patients. And one of the studies, it clearly showed that the percentage of patients achieved a better control with the education program with the patients who didn't complete the educational program. So it is well evidence-based as well. Now, we'll come to slightly more sort of in depth. I won't go into too much depth because I think, considering the audience we have, it may not be of interest to everyone. And we'll go sort of to different difficult asthma, different phenotypes, and probably risk factors and treatment options if you have some time. The difficult asthma phenotypes, which we categorize, can be, unstable asthma, which we also call brittle asthma or nocturnal asthma or asthma related to the menstrual period. It could be steroid naive or a poor response to the treatment, which could be steroid dependent or steroid resistant. And then, as I've said, a new category which is coming to the surface is known as fixed asthma or fixed airflow obstruction asthma. And that is a group which I believe is more difficult to treat, especially in countries like Pakistan, where people are less adherent to their treatments. In terms of brittle asthma, we divide them again into two types, type 1 and type 2. In type 1, there is a wide variability in peak flow in spite of the maximum treatment. Type 2 is different in a sense that patients are well controlled, and all of a sudden, because of any reason, there's a dip in the peak flow, and they are sort of called type 2 brittle asthmatics. And nocturnal asthmatics is another category, another phenotype of difficult asthma, where patients get more symptoms at nighttime with the highest peak expiratory flow rate variability at nighttime. And then there's a category of difficult asthma which is in relationship to the periods, where people are getting a stable, peak flow, and then all of a sudden, with the premenstrual period, there's a dip in the peak flow, which gradually gets better, uh, with the periods cycle passing through, and that is the time period where, in spite of the therapy, patients are getting a lack of response to the treatment, and in spite of using oral steroids every month, their symptoms are not well controlled. So this is the category which we have to identify based on the history of their periods and menstrual cycle, which can correlate with their asthmatic symptoms. There's a subgroup of difficult asthmatics which are sort of poor response to corticosteroids, which could be either non-compliant, a wrong diagnosis. The dose is too low either for the patients, they've got a high BMI, and if you're giving them conventional dose of 30, 40 milligrams, it may not be enough. It could be due to other medications causing increased metabolism of steroids. And there's a very small group where they can get the receptors resistance or a complete resistance in spite of taking all the cofactors away from affecting from the factors which can affect the response to steroids. Now, in terms of corticosteroid resistant asthma, there are two different types. One of them is sensitive, where they show a very gradual, slow response to the steroid therapy, which, a group of patients who do not respond to conventions, short cycles of steroids, they may have to be given a longer cycles of steroids. However, the other concerning group is the corticosteroid naive or resistant asthma, where, in spite of getting them maximum steroids for their body weight for a maximum period of time, we are not getting a good control of asthma. And I think that's the most challenging one as far as the clinical practice is concerned. Then we briefly previously talk about the fixed asthma, where the studies have shown that in fixed asthmatics subgroup, the smooth muscle mass is much larger and bigger than comparing to a subgroup with a moderate asthma. So there's a remodeling of the smooth muscles with thickening of the smooth muscles, and that is a phenotype which is again very difficult and challenging to manage. And if you take a biopsy, we can see that smooth muscles are very hypertrophied in this phenotype of asthmatics. So finally, I would be coming to the treatment options which we have for difficult asthmatics. In terms of the list, it is growing slowly and steadily. However, the current list we have are the conventional therapies with the ICS, LABAs, and the long-acting beta agonists, the antimuscarinics, tiotropiums. Then we have got anti-inflammatory drugs, which include steroids and PDE4 inhibitors. Macrolides have interestingly got a role as well in severe asthmatics. Then immune modulators like azathioprine, methotrexate, gold can also be used. And finally, a lot of interest being generated in a new therapy known as bronchial thermoplasty, which has found some good promising results in managing difficult asthma. So sort of a learning style again, so slide for the PGs and new trainees is that where all these different medications work. Uh, we look on the inflammatory pathway, and then we don't do that test here in Pakistan, but we do it in UK, where we do the induced eosinophilic sputum eosinophilic test. If the sputum is showing increased eosinophils, these are the group of patients which respond very well to the inhaled corticosteroids because of the inflammatory cascade and pathway which these patients go through. And the patients who are in the sort of the late response to the inflammation, they can benefit from the LABAs or long-acting beta agonist. With the neutrophilic asthmatics, where they've got predominantly neutrophils in their sputum, long-acting beta agonist is the treatment of choice rather than the ICS. Now, a couple of slides about long-acting beta agonists. There have been lots of studies which are sort of published, and they've clearly shown that the long-acting beta agonist can reduce the IL-8 and polymorph neutrophil infiltration significantly 4 weeks down the line while the patients are using the LABAs. Similarly, in the last few years, we have seen that tiotropium or Spiriva has been added to the asthma algorithm because of the different studies we had. And in one of the studies, which was published in 2010, where they run through the different treatment options in different periods with tiotropium by doubling the steroids and using the LABAs. And then there's a switchover period between the different treatments, and they monitored those patients for fairly a long time, for good going 52 weeks, by switching off and changing the treatment for all these different groups. It was a fairly large study, and in that study it clearly showed that if you use tiotropium alone, there has been 5.4% patient who respond, but if you add tiotropium with ICS, the number increased to 7.2%. If you use what we call it a LAMA-LABA combination with long-acting anti-muscarinic and long-acting beta agonist agents, currently we don't have too many options in Pakistan, but that is sort of in a use in UK, and that reduces the use of ICS, and that is more useful in neutrophilic asthmatics. There has been increased response to the therapy to 11.4 as compared to 4.8 and 5.4. And using the salmeterol and ICS, interestingly, didn't show a very good response, but I presume it's more to do with the asthmatic phenotype. And if you're using the tri or trilogy drug, we're using the LAMA, LABA, and ICS, shows a very significant response of 17.5% as compared to the rest of the groups. So overall response rates for tiotropium were significant for tiotropium to 41%, to 44% for LABA, and to steroids, interestingly, it was only 34%. A couple of slides about the macrolides. Clarithromycin has shown in studies to reduce the IL-8 protein before and after the use. So with comparing to placebo, there has a reduction in the inflammation with the macrolides. It can also be used. Again, with the macrolide therapy, we can see that with macrolide therapy, there has been improved quality of life as per one of these studies. I can appreciate I'm running out of time, Zohaib. If I'm running out of time, just let me know. I'm just left with a couple of more slides.
So we have time.
Okay, fine. So I'll just come to the higher end of the treatment, and that's why I sort of took a pause here. One of the new things which have come to the surface in last decade is anti-IgE or amalizumab, which is used for difficult asthmatics which are not responding to any of the conventional therapies we have discussed so far. So amalizumab is a monoclonal antibody which binds to IgE. It is indicated for adults and children over 6 years of age, and it's mainly for those patients who are not responding in spite of being high-dose steroids and LABA with frequent exacerbations. But most important thing is that we have to make sure that their IgE levels are high, because it is more to do with allergies, and amalizumab is indicated for the patients who are having high allergies. It's normally given like insulin injections subcutaneously every 2 to 4 weeks. IgE must be less than 1300, but in UK we're using it for less than 1500 in clinical practice. The reason is with the higher IgE, there's a very high risk of anaphylaxis. And the dose which we can use up to is about 1500 international units as well. There have been tons and tons of studies for IgE. It's very well established. It's in the GINA guidelines. It's in all the guidelines. One of the papers clearly shown 26% reduction, which is a very significant reduction in severe asthmatics who have been on oral steroids. And it has also had an effect in improving the FEV1 by 2.8% with 13% improvement in quality of life questionnaire. As all medicine have side effects, they can cause localized skin reaction and anaphylaxis. I think in Pakistan, I would add that the cost of the drug is very high. It's, to my understanding, a few years ago, when I asked for one of my patients, the cost was nearly 40 to 50,000 a month. So it's a very significantly costly drug, but it can be used in appropriate group of patients. Then other immune suppressants which you can use are methotrexate, cyclosporine, oral gold, and they can be used in predominantly in those patients who are steroid resistant or naive patients. Uh, I think it's been a long time I've used continuous subcutaneous terbutaline, especially after the entry of omalizumab. It was probably way back in 2003 and 4 when I started my respiratory training, when I used a subcutaneous terbutaline. But in the last decade or so, we haven't used that often because we have got better options rather having. But it's still one of those things which can be used just like insulin pumps in difficult asthmatic patients. There's no good evidence for colchicine or IV immunoglobulins or anti-TNF. Uh, One of the other drugs which showed initially quite promising results, but then with the further trials didn't show too good promising results, was the PDE4 receptor antagonist, roflumilast. The initial trials which were done where they used the different strengths of 100, 250, and 500 over a period of 12 weeks, followed by a 40 weeks extension time, and they showed a significant improvement in FEV1 with 40-week time period in group of patients who were given roflumilast in asthmatic group. And the study was sort of quite promising that there was a change in FEV1, but further studies were not that significant, and it's not in clinical practice that often. The final thing is about the bronchial thermoplasty. I won't go into too much depths and details, but it's normally done through bronchoscopy. A lot of interest has been generated in the last 10 to 15 years, and it is predominantly for the group of patients who have got bronchial remodeling with smooth muscle hypertrophy. And the concept is that you apply the high frequency thermoablation to the bronchial walls, causing microwaving the bronchial muscles and reducing the muscle bulk, reducing the airflow obstruction, reducing the airflow limitation. And one of the studies, which was a randomized double-blind sham controlled trial, where the patients had bronchial thermoplasty in different intervals. They were assessed at 3 months, 6 months, 9 months, and 12 months down the line. And they were the group of patients who were given everything, including ICS, leukotriene antagonist, omalizumab, oral steroids. More importantly, they have to quit smoking for at least 12 months because smoking has an impact on the bronchial epithelium and with a sort of a lack of response with the bronchial thermoplasty. And the results in terms of the changes in the quality of life showed a significant improvement in the sham group as compared to the bronchial thermoplastic group. And the study actually showed that people who had bronchial thermoplasty as compared to a sham group, there has been improvement in the quality of life questionnaire. However, the study was having certain limitations as it could have a big placebo effect if somebody is going through such a massive procedure, and they had significant side effects with recurrent infections in the first few weeks. And then the other important questions like asthma control and the rescue use, the answers were kept unanswered with the bronchial thermoplasty group. So on the basis of AIR2 model, the bronchial thermoplasty uh, is something which could be an offer and a hope to improve the quality of life and severe exacerbations. We all know by now that it has got many phenotypes, and probably the patients with the bronchial remodeling with the smooth muscle thickening would be the group which might benefit more than any other group. We still need lots of studies. It's in clinical practice in UK, but we use it only in patients who are not responding to all the conventional therapies we have. So that sort of concludes my talk for the day. And thank you very much for listening to me. I know it's a very boring topic, but I'm happy to take any questions or any comments if there are any.
Sajjad, thank you very much for your such a nice talk on a very important topic, especially in terms of the emergency uh, department. My question is that people who are known to be difficult, suffering with difficult asthma, when they present to emergency department, do we, in terms of say their management, have to be really aggressive from the start, or we can just follow those stepwise approaches of the way we've been following those guidelines of the British Thoracic Society? So if you can just elaborate on that for me, please, that might help us in improving the management of these patients when they attend the emergency. Thank you.
Sure. Yep. Thank you very for. I think it's a very good and valid sort of question. I think the answer is that in an emergency, we all know that you guys can be very very busy most of the times, and if with the asthmatics coming up, most of the asthmatics you tend to see are those patients who are very unwell and they are with moderate to severe asthma. And I think my advice and suggestion would be that we should treat them with the appropriate therapy which we use for moderate to severe asthma to stabilize the patients and to admit the patients if they are not very well. And and they would probably need steroids and nebulizers and admission, so forth, depending upon their clinical status. I think coming sort of to the more smaller, finer details like the background histories or say other things like comorbids, it's a time restraint and it would be very challenging for you guys to go into the depths of all these different things. In my view, if you guys think that the patient is very unwell, you should treat them aggressively with the steroids and conventional therapy. But if you guys think that there could be some other comorbid, say like psychological factors, say like gastroesophageal reflux disease, you can always either refer them to one of the respiratory physicians or you can refer them to the appropriate consultants like the psychiatrist to have further evaluation or to the gastro team to have a further evaluation. So I think it all depends on the time restraint and the availability of resources. But I think asthma is something which can be life threatening. And with the stress and with the workload I see in ER, if I was in your place, I would treat them aggressively. But you must have seen a few of my patients who come almost every day. I won't name any one of them, but you guys probably know that patient very well. And we have been very sort of clear in our management. We're not going to give her any more steroids because I don't think that is the difficult aspect. It's more to do with the psychological element. So I think as the primary respiratory physicians, we have to put certain guidelines for you guys in our notes so that the patients don't get unnecessary treatment. But at the same time, we have to be careful to watch for these serious sort of signs and symptoms and to manage them appropriately as it's a life-threatening condition.
Thank you, Sajjad. I think we agree on that. That we'll treat patients initially on the symptoms and then further digging up and finding out. And if we have a guideline, as you said, from the few patients which we know, then it's much easier. Thank you very much, Sajjad. Once again, it's a very important topic, and thanks for your time and effort. Thank you.
Thank you very much. So I think we can conclude the session if there are no further questions. It was a pleasure to have you all. Thank you very much for listening to me. And I hope it's of an help to to everyone, and especially to the junior doctors in managing day-to-day asthma. Thank you once again for your time and listening to me.